Tell me a little bit about yourself and your position.
Okay. My current position is what they call a senior political advisor or policy advisor, senior policy advisor to the North Carolina General Assembly. And in that role, what I do is provide research, I provide assistance in drafting bills, in reviewing legislation, in determining policy positions, and not elected by anybody, and so I'm not the decision maker, but I do feel like it's important for them to have knowledgeable advice, and I do a lot in health and human services, most specifically in the area of Medicaid, and even more specifically in mental health, developmental disability, and substance use disorders. Before that, I was I was on the faculty at UNC Chapel Hill for a number of years, and then before that was chief of developmental disability services for the state. So I think one of the things that's valued in the General Assembly is that I have experience in the state agency and I know how to implement policy, and I know how to have input in that, and I know how budgets work, and I know how the federal government works, and a great deal about CMS. And so I think I'm well positioned to do what I'm doing now.
Can you explain what Medicaid reform means?
Yes, I can. In years past, North Carolina has functioned under a fee-for-service system. What that means is you deliver a service, and this is in behavioral health, IDD, physical health, long-term care. A provider delivers a service and they get paid directly by Medicaid. Our Medicaid budget hasn't been so great in North Carolina. We've been over budget for probably at least the last 6 or 7 years. And so one of the things that we did unique in North Carolina is in 2011 we decided to get the behavioral health IDD budget under control. And we moved to a system of managed care in which the agency, in our case, local management entities, get a set amount of money for each person they serve, and that's capitated. And they have to provide services to eligible populations within that amount of money. What that results in is a more predictable budget. It's been very successful in our state, and so the state, seeing the broader Medicaid budget being out of control a couple of years ago, started looking at the possibility of managing care, that is capitated at-risk managed care for the larger population.
Can you explain what capitated means?
Yes, it means that you get a certain amount of money per person that you serve. And if you save money, if you're in a public system, you get to reinvest that money saved. If you're in a private system, then that money is considered profit, and you achieve that much profit. But you enter into a very specific contract. If I am a managed care agency, if I'm Aetna or Blue Cross, or if I'm Alliance Behavioral Health, I enter into a contract with the state and I say, okay, how many people am I supposed to serve? What services am I going to manage? Considering the infrastructure that I'll need to have to do that and all else that takes me to be a good manager of these services, you pay me this amount and I will deliver those services. That's the contract. And if you go over that amount, then there are penalties written into the contract. But for the most part, if you're a good managed care company, you don't. You stay within that.
How is North Carolina approaching Medicaid reform currently?
It's very interesting, and it goes back to the idea of the behavioral health IDD managed care component. Unlike other states, we've had some experience with managed care. Most of the states are going to some kind of managed care now. We've had some experience with a very difficult, very costly population, and we also have had something called Community Care of North Carolina, in which we have developed a network of physicians, and we have provided incentives to those physicians to do more than just direct care. They've done care coordination, they've provided preventive care. They've set up what we've called medical homes for individuals so a person can get some comprehensive care with the medical home. We in North Carolina are going to build on both of those. Very smart thing to do. We're going to build on the behavioral health system, IDD system, managed care, and on the kind of quasi managed care system, which has more to do with care coordination. But those two components are very important coming together to be the foundation of what we're doing now. So many people are saying, are you carving out behavioral health IDD? In essence, we're carving it in. Unlike many other states. And what we're trying to do is to use these programs as models for the larger behavioral health system. And it's going to be a challenge for our state. We've decided to do it in a way that's a little unusual, and that is we're going to have a hybrid model. What does that mean? What that means is that we've decided that we're going to allow commercial managed care companies, large insurance companies, into the state, up to 3 of them, to manage physical health care, and then statewide. Each of them can manage statewide. And then up to 10 what we call provider-led entities, which are, as they say, provider-led managed care entities. They're more homegrown, let's say that. They're usually not for profit, and so they will reinvest money. But we're going to allow competition in North Carolina. We're going to continue to manage behavioral health care and IDD through the local management entities program that's been expanding since 2011. And we're going to continue to do that at least for a while. In the legislation that supports Medicaid reform, the language says that 4 years from when the first physical health contract is let, that's a period of time within which the LME MCOs will continue to operate. There's nothing, the legislation is silent after that, which means we're not sure what's going to happen after that. If the LME MCOs continue to do as well as they're doing right now, we believe they'll continue. But what that means for consumers and families and providers of service is probably 5.5 to 6 years. They will continue to be able to depend on the LME MCOs to provide their behavioral health IDD services. As these other physical health programs come up and begin to operate, they will, if they're Medicaid, if their services are provided by Medicaid, then they'll need to sign up with one of these programs for their physical health care.
What exactly does an 1115 demonstration waiver require?
Well, just that. It is a demonstration. It's called an R&D, research and demonstration waiver. And you know, Medicaid is an interesting program, largely funded 2/3 by the federal government, 1/3 by the state, usually. And we have a Medicaid state plan. We can include required services and optional services within that plan, and we do. We have a rich array of optional services. But there are some times that a state wants to waive the requirements that are included in the Medicaid state plan. In developmental disabilities, we've had a long history of that. We used to say that, still say, essentially that the only entitlement that people with IDD have for service is a state institution or another intermediate care facility for developmentally disabled. That's the way we started, until a group of families came together and said, we want to keep our family member at home. We don't want them to go into a group home or an institution. So we wrote a waiver. And what that does is to waive the requirement that somebody goes into an institution. Well, this is a research and development and demonstration waiver. And what it does is allow a state to waive almost everything. A state goes in and says, this is our plan. We're going to move from fee-for-service to managed care. We're going to require person-centeredness. We're going to require value-based or outcome-based measurement. We're no longer going to pay just for the number of people you see. We want to pay for you to provide the service that's going to get a value outcome. And that's a very good way to go, but it's also very difficult to achieve. It's a big jump for North Carolina to do that. So what we do through an 1115 waiver is we communicate with the Centers for Medicaid and Medicare, because they have to approve this if we're going to do it, and we convince them through our application that we're going to make sure that people get the highest quality services paid for by Medicaid dollars, that we're going to have qualified providers, that people are going to be safe, that their services are going to be person-centered, that we're going to give people services that are deemed medically necessary for that individual, and we're going to measure outcomes. We're going to be accountable to be able to do that, and that we're going to do it under a capitation. That's what we're convincing through an 1115 waiver. There will be a bunch more innovations in that. In fact, North Carolina is proposing to set up an innovation center for Medicaid, and so it'll be kind of a think tank, so that folks who have innovative ideas about how services can be delivered and managed can come together and hopefully do some demonstration of those and have those evaluated. So it's kind of an exciting time, but it's also a perilous time. So we're forging ahead in North Carolina.
Great. How can people with disabilities and their family members learn more about Medicaid reform in North Carolina?
Well, the Department of Health and Human Services is really trying to make sure that there's an open door for review and input. They've put some very good information online, and so that information is available to everyone. I'm not very clear on how accessible it is for people with disabilities. To be honest, I haven't looked very carefully to see. I understand that this is one of the ways that we're trying to make this information accessible to people with disabilities and their families, and I think this is a great idea. There are going to be a series of public forums, and if I were a person with a disability, or if I were a family member, I would be sure to attend the one nearest me. And I'm sure that there'll be material provided and an opportunity to ask questions, and there will be no stupid, silly questions to ask. If you are being told something and you don't understand it, or it doesn't make sense to you, or you think that it's not what you need or want for yourself or your family member, you need to raise your hand and say that, because the Secretary of the Department of Health and Human Services has said that's what he wants. So we're going to hold him to his word.
Similar type question. What is the best way for people with disabilities to advocate during this Medicaid privatization process for the next few months, and then also for the next few years to come?
I'm going to challenge people with disabilities and their families to do this. Sit down and think about what you have. If you're receiving services right now, look at what you have and what you value in what you have. Let me tell you what I mean by that. What I mean is, do you like the services you're receiving? Do you like the provider you're receiving those services from? Not everybody's going to be fully satisfied, and that's another thing that you can say. These are the things that I like, these are the things that I wish were changed. But mostly I want to challenge, what are the things that are very important to you, that you really like and you want to maintain? Do I like the fact I can pick up the phone and I know who to call? That I call Alliance or Cardinal or one of the LMEMCOs. Do I like the fact that the people working in that management agency know and have relationships with schools, social services, public health, criminal justice, all of the local agencies? Do I like the fact that that public agency has direct and ongoing interaction with the General Assembly and with the department? Do I like the fact that they are being held accountable and that I can look at their contract and see what they're being accountable for? And the reason I would challenge folks to do that is those are the things that you make sure that you're not going to lose. because this is a perilous time. You know, there is the potential, as we've seen in other states, that behavioral health IDD services are given to a large insurance company to manage. That's quite different than the local system that we've got now, the regional system that we've got now. You know, you think about how you respond if your insurance coverage is through Aetna or Blue Cross Blue Shield and you've gone to the hospital and you need help with this or that or the other. It's really quite different than what we see in the behavioral health IDD community now. Most people value that, and if you do value that, then you need to be vigilant and make sure that you're not going to lose that in this process.
Do you have any other tips or advice for how people with disabilities and their family members can make a difference in the system?
Absolutely, I do. We don't see as many people with disabilities and their families in the halls of the General Assembly as we used to. And I think part of that has to do with the fact that they're satisfied with the services that they're getting that are being managed by the LME-MCOs, and that's a great thing. But your voice needs to be heard. You need to talk to your local legislator. Find out who your member of the House of Representatives is. You can go on a website called ncleg.net, www.ncleg.net. And you can look up who your senator is, who your representative is, and contact them and say, I'm afraid that I'm going to be losing some of my services, or I'm afraid that in this transition, I'm not going to be able to get what I'm getting now, because they're the ones that initiated this Medicaid reform. The reason we're doing that in North Carolina is because they passed legislation that directed the Department of Health and Human Services to move on this path. So they need to know from their constituents, from the people they represent, what they like, what they're afraid of, what they don't like, what they're really anxious to see happen in this. Absolutely. In addition to being very vocal in the public forums and online with the department, you know, make yourself knowledgeable. It's a complex enterprise. So I've read the waiver application a number of times and I'm still finding things in it that I'm scratching my head about. So it's not easy, but you can do it. And ask questions. Don't be afraid to ask questions about it. That would be my advice.
Great. Well, thank you so much for your time today. We really appreciate it.
You're welcome. Glad to help.